Good evening, everyone. Many thanks for joining to our virtual Grand Rounds in Radiation Oncology lecture series. You know our series quite well, a very quick introduction. We aim to present you the latest science presented by the top speakers in our field, and that in an interactive format. So please, I hope you have many questions for today. Use the Q&A functionality to ask them in between. We happen to start our series every first Wednesday in the month. It's between 5 and 5:30. Please apologize. This day will be slightly longer because we have a very important topic where we have lots of updates. Um, Also, many thanks to our societies which are supporting and endorsing our series, Estro, Sastro, and the German Society. So many thanks already. And I'm also reminding you that all the talks which are being given are being recorded. So if you have missed anything. Today, we are addressing the field of hepatocellular carcinoma and the value of radiation oncology, in particular SBRT. The energy trial has just been recently published comparing SBRT and sorafenib. It was a landmark trial, I would say, for our field. This was not the only landmark trial being published in the last couple of weeks and months. There has been quite a number of evidence being generated, and most of them supporting the application of SBRT not just on retrospective, but in prospective and randomized settings. And that has been adapted and adopted in the guidelines. For the very first time, we have an international guideline where our current speaker has also been contributing, where SBRT is being addressed and is now a guideline recommended treatment. So it's a huge pleasure and honor presenting you today's speaker, Professor Laura Dawson. She doesn't need any introduction. You know her very well. She's being chair of the Department of Radiation Oncology at the University of Toronto. She's professor for Department of Radiation Oncology, again at the University of Toronto. She's a staff radiation oncologist there. We know her from a pioneering role in the field of SBRT. If there would be one person who would kind of kickstart it, not only kickstart it, but brought it into the guidelines, it is Professor Dawson in the field of SBRT for liver, but also for other malignancies. And she has been the PI of numerous practice-changing trials. Laura, it's a pleasure and honor having you in our lecture series. We're looking forward to the presentation of the energy trial and also putting it into context. Laura, many thanks for joining, and the floor is yours.
Many thanks. This is a wonderful series, so it's my pleasure to be a part of it. Let me see if I can share my screen. All good? Excellent. Excellent. The only thing that would make this series better would be being in person, but I really appreciate the effort to have interactivity and Q&A. I'm looking forward to that portion of the talk. And this is a topic I feel very passionate about. And I love the title that I was given by Chair Professor Guckenberger, SBRT for HCC, finally and officially ready for prime time. And I really do believe the tides are changing, and this is a very exciting time for liver cancer radiotherapy. Some disclosures. I'm going to start by talking about the Barcelona Clinical Liver Classification System. It is not a staging system, but it is one that has really led and been impactful in changing guidelines, changing treatment around the world. It has evolved. This is a 2022 system, and it is more flexible, more complicated. There are many more treatments. There is a lot of benefits to this, recognizing there are sub-stages within some of these stages. For example, Barcelona Clinical Classification System C includes patients with vascular invasion and metastases. They're very, very different, as we know as radiation oncologists. It also allows patients to consider other treatments if they are uh, changing stage with a response or worsening stage. And there's a little caveat that it depends on local expertise. But a big flaw is that radiotherapy is not mentioned. And that is true. This was a few years ago, but there was evolving evidence. And just a comment, guidelines change and changing in practice is far more difficult than I anticipated decades ago. And it's not only doing trials and advocating and speaking, but it's also raising awareness and being present at tables, at other therapy and other society meetings. This was a letter to the editor just pointing out, the notable absence of external beam radiation. Professor Reg, who leads this Barcelona group now, is very well aware of this and involved in collaborating with some work to try to improve evidence and improve the presence of radiation oncology. But it does take patience. I anticipate the next BCLC classification system will include radiotherapy. I sincerely hope so. So before speaking about SBRT, I'm going to briefly mention palliative radiation, really because it just highlights how responsive to radiation hepatocellular carcinoma is. This was another study in liver cancer that was published this past year in Lancet Oncology, a pragmatic Canadian study looking at single dose radiation for pain relief of patients with end-stage HCC or liver mets. Very simple, the least expensive pragmatic trial ever done in CCDG history. Patients with no other treatment options in substantial pain despite analgesic, one-to-one randomization, primary endpoint at day 30. Was there a clinically important reduction in pain? Patients had to have stable, severe pain despite interventions. Crossover on day 30 was permitted if patients continued to have pain. Secondary endpoints included survival, quality of life. At the end of the day, this was a positive study. There were important and significant improvements in all the pain endpoints. The BPI pain tool that we use for bone mets was used, with worst pain being the primary endpoint. You can see improvement in patients who had radiation. The majority had clinically important reduction in pain by 2 or more points. And importantly, a sensitivity analysis that assumed worst pain for all missing data also was positive. So it really met its primary endpoint. Changing practice in that single fraction radiation with an antiemetic before can help patients in pain. So a question is there harm to this? And although a secondary endpoint, we looked at overall survival to be sure that patients with impaired liver function, massive disease, weren't being harmed by 8-gray and 1. And in fact, if anything, there was improved survival in those patients who had radiotherapy, as shown in the right curve, red, compared to those who didn't receive radiotherapy, despite there being crossover in patients. This did not meet statistical significance. It was not powered for this. It's hypothesis generating. However, I would say that even low dose may benefit patients. And looking at the HCC cohort, again, hypothesis generating, but the hazard ratio for survival was quite low. Rationale for further trials of even low dose in HCC and just showing the importance that radiation can make, even when it's not curative. So that sets the stage. So when we move to the next question, how can we help patients in terms of survival, ablate, and those patients where SBRT has a role? So in this Barcelona clinical staging system, very early stage patients and early stage can be cured, traditionally with resection or transplant or interventional radiology ablative therapies. There is good evidence. One of the first randomized phase 3 studies was in early stage cancer patients, very small, 2.5 centimeters or less tumors, with a comparison of proton radiotherapy to radiofrequency ablation. It was 10 fraction proton radiotherapy, 66 and 10 gray. When you look at per treatment arm and intent to treat arm on the right, you can see the radiation curves in red are definitely non-inferior to RFA, and it was a non-inferiority study. And again, looking at local progression-free survival, if anything, there's trends or significant improvements with radiation versus RFA. So this is some good prospective randomized long-term data, again, showing survival, 4-year survival rates, 75%. It didn't change practice, and there was some question, can this be done with photons and SBRT? Well, I'm happy to say, as you heard at the beginning, there have been many trials. And this was one of the randomized phase 3 trials that was a similar study, but looked at radiofrequency ablation compared to SBRT delivered in 3 fractions. And this study looked at single HCCs, 5 centimeters or smaller, with good performance status, good liver function, a very good set of patients. The patients had recurrent hepatocellular carcinoma after prior resection or RFA. Local progression-free survival was better in patients with SBRT, as you can see, at 2 years, 92% versus 84% with radiotherapy benefit that was sustained, as you can see in the plots. RFA, more patients do recur at later years than those with SBRT, confirming what we saw with photons. What about survival? With protons. Well, similarly, survival was no worse, and progression for free survival was no worse. Is in fact trending improved with SBRT shown in yellow in these curves. And looking at tumor sizes, you can see yet in both arms, survival was better, even at 3-4 years for the small tumors, but pretty good and rivaling surgery outcomes in those patients with lesions 2 to 5 centimeters in size. And again, no statistically significant differences in survival. So level 1 evidence for photons. SBRT is a standard of care for early stage tumors and can be used. We can talk in the discussion perhaps about when is best SBRT versus RFA. I think there's a role for both. So in intermediate stage, so multifocal lesions, those lesions that are larger, refractory to perhaps trans-arterial hepatic therapies like TACE, what is the role of radiation? Again, the first randomized studies were of protons. So this is a study done from Loma Linda. It had an update. It didn't complete as planned accrual, but still is very important, showing statistically improved local control. Progression-free survival curve shown over on the bottom improved as well. There was similar survival. In this group of patients, many went on to have a transplant, and thus there was not a difference in overall survival. There was less toxicity with radiation, less estimated cost. And in those patients who had a transplant, a quarter of the patients had a complete response to radiotherapy. So again, showing the effectiveness of radiation, even those patients with more advanced disease. What about photons? There have been multiple randomized trials with SBRT versus TACE in patients with intermediate disease or those who were refractory to standard ablative therapies. This is one of them from Italy, and it shows similar findings too with protons. So with SBRT in 3 to 6 fractions, a significant improvement in local control, clinically meaningful, statistically significant, with also statistically significant improvement in progression-free survival, shown in the yellow curve on the bottom. This was not powered for survival, and like many of the other randomized studies, they were small. And given that they didn't see differences in survival and that they were small, they didn't tend to change the needle in terms of guidelines on their own. And again, another study that brought all these together, and I think a really important body of work by Freddie Escorcio and his team, a multidisciplinary team. They looked at all these studies and put it together in a meta-analysis. And this is a great resource that I'd refer you to. Basically, 40 randomized studies of more than 11,000 patients. 6 of those randomized studies were comparative with radiation. And the bottom line is that radiation was better than or equivalent to TACE. And looking at this curve for progression-free survival on the left, overall survival on the right, looking at comparisons to all treatment, the hazard ratios are meaningful for progression-free survival and survival when radiation is compared to treatment. So a hazard ratio of 0.69 for improved overall survival for radiation versus anything, as you can see on the right, and that's statistically significant. Important when comparing to TKI therapy and also to TACE. And there's lots of other information in this review, but I think this is one of the strongest evidence, especially for that group of patients who otherwise may be treated with TACE. And the question that comes up a lot, and not the focus of this talk, but is how about transarterial radioembolization? And just to say, the similar comparisons were done in this body of work, and there were benefits to TARE, but as you can see in this curve with TARE, not quite as statistically significant or as meaningful as with external beam radiotherapy, at least based on the prior studies. Advanced stage. So this is where invasion into the vessels is a poor prognostic factor. It may decrease liver function and make patients more challenging to treat with any kind of therapy. Outcomes are worse, whether patients are treated with surgery, non-invasive local therapies, regional therapies, or systemic therapies. This is a challenging group of patients. It's extremely heterogeneous. And I think one thing we've done and others in radiation oncology have started to characterize the degree of macrovascular invasion. A little bit of invasion is a poor prognostic factor, but not at all as much as massive invasion in the entire portal venous system or entire hepatic venous system with, for example, complete occlusion of the IVC. There's rationale for systemic therapy given that this is a marker for increased risk of microscopic disease, but there's also a strong rationale for therapies that can effectively treat the cancer in the vein, such as radiotherapy. And perhaps you could argue there's different rationales for different combinations of local or regional plus or minus systemic and vice versa. But I would advocate that all of these patients should be considered for treatment with radiotherapy, especially if they are too poorly or unable to have systemic therapy. So what is the evidence in this group of patients? Well, there's one very important randomized study from Korea that is a randomized phase 2 study of 90 patients looking at TACE and radiotherapy combined with together versus sorafenib. That was the standard of care when this study was done. The median tumor size was 9.5 centimeters. All had very good liver function. There was crossover permitted when patients progressed, and the primary endpoint was 12-week progression-free survival. Note that 90% of the patients crossed over. So most patients ultimately will recur and don't have great responses to TKIs and sorafenib, as I mentioned originally. So despite the fact that most patients in both arms did receive radiotherapy ultimately, there was statistically significant and clinically important improvement in all outcomes, including 12-week progression-free survival. That was the primary endpoint, with an improvement from 25% in those patients who had sorafenib alone to 78% in those who had TACE and radiation, with similar improvements in survival, a median of 10.8 months to 13.8 months. And again, despite the fact that those who had sorafenib ultimately received radiotherapy and TACE at a later time when they progressed. It's a randomized phase 2 study. It was in Korea. It didn't change the needle as much as I thought it would. There have been other single arm studies, intriguing, important. And as mentioned, I was very happy that finally the Energy RTOG 1112 study was published last year. I hope this will help to change the needle, and I think it has already. And this was a randomized phase 3 study of SBRT with sorafenib versus sorafenib alone in advanced hepatocellular carcinoma. This study, I wish I could say was simple. It wasn't simple. It was one of the more complicated studies when it was launched at Energy. It was personalized radiotherapy with personalized dosing, immobilization, allowing an evolution of technologies during the trial as image guidance was improving and changing over time. And there are many different platforms for which we can deliver SBRT for our patients. Patients had to be suitable for sorafenib and or lenvatinib first-line therapy in that they had good liver function and they had vascular invasion or small burden of mets, or else they were treated already by TACE and did not have response and progressed. They had to have active disease. And unlike most SBRT trials in our field, this included patients with very large cancers, up to 20 centimeter tumors in the parenchyma of the liver, up to 5 lesions, up to 3 centimeters of extrahepatic disease. And any degree of macrovascular invasion was permitted in the portal venous system or IV system if liver function was good and if it could be treated while respecting the organs at risk, including the liver. The primary endpoint was overall survival, and stratification a priori included degree of macrovascular invasion, underlying liver disease, North American versus not, and a burden of cancer as a surrogate, the ratio of HCC to liver volume. 1-to-1 randomization. Standard care sorafenib versus SBRT, 27.5 to 50 gram 5, followed by half dose sorafenib and escalated up as tolerated after assessment. The inclusion criteria are here, as mentioned, needed to be suitable for TKI, included quite large tumors up to 20 centimeters, couldn't have had bleeding within 30 days. The prescription dose was personalized based on mean dose, and this is in the manuscript. It allowed very large tumors like this to be treated. And at the end of the day, the study was stopped early due to a change in the standard of care, but we kept the same a priori hypothesis about hazard ratio for survival and typical patients as described and as treated with radiation were treated with three-quarters having macrovascular invasion, the most having in the main portal vein. The median tumor size was just under 8 centimeters, and there was a variety of underlying liver disease. A majority had multiple tumors, advanced cancer patients. In the end, the median tumor dose delivered was 35 gray and 5 fractions with a range as shown in the plot here, including those patients intent to treat who did not have treatment for, did not receive it in that they declined it or did not have liver function appropriate after randomization before treatment. And this happens with advanced patients. In the sorafenib arm, 21% went on to receive SBRT at the time of sorafenib discontinuation. The overall survival is shown here. The median was improved from 12.3 months to 15.8 months. And on a multivariable analysis, including the prognostic factors we knew were important, the performance status, metastatic stage, the degree of liver function, Child-Pugh A5 or 6, which is actually clinically important, as well as the degree of macrovascular invasion. The hazard ratio was 0.72 with a p-value of 0.042. So important improvement in survival that at the time was meaningful compared to other studies. We've seen similar improvements in overall survival now looking at immunotherapy compared to sorafenib, but not so much with other local regional therapies compared to any systemic therapy. The forest plot of subgroups shows similar outcomes in all subgroups. I would just draw your eye to the macrovascular invasion subgroups and looking at those that have macrovascular invasion. The majority of patients, as stated, was quite dramatic improvement of the 12-month survival from 8.8 months to 28.4 months. This is subgroup analysis, hypothesis generating, but just really highlighting that perhaps the greatest benefit of the treatment was in this cohort of patients who had very advanced hepatocellular carcinoma in the veins. And we know that all of our treatments are not very effective and patients can have a dramatic decline in liver function if not adequately treated. So with better treatment, we can improve their function and help patients live longer. So what about the other outcomes? Well, progression-free survival, time to progression, also clinically important, statistically important improvement in outcomes. The median progression-free survival was improved from 5.5 months to 9.2 months with a hazard ratio of 0.55, important based on ASCO guidelines of what can make a treatment meaningful to patients, similar for time to progression. How did this affect patients in terms of their quality of life? Well, we did have a companion study for those who consented doing patient-reported quality of life analysis. The a subset of patients completed this and less than we thought, so we did not do statistical analysis on this, but this is still to show this is consistent with what we saw with the survival and progression-free survival, that in those patients who completed the FACT quality of life tool, the majority of patients who had radiotherapy, as shown on the right, had improved quality of life using this tool at 6 months compared to baseline, about 35%. And almost half had stable quality of life at that time, which is in contrast to those patients who had sorafenib alone, where the majority had a decline in their quality of life at 6 months. Consistent with the fact that we're not hurting patients, and I'm not showing the comprehensive adverse events in this talk, but I would just highlight to you that there was no significant difference. And if anything, looking at the serious adverse events such as bleeding and life-threatening liver failure, not attributable to any therapy, there were more events in the sorafenib alone arm, highlighting that the disease itself is what is probably responsible for most of the adverse events. And if we can control the disease effectively, we're more likely to improve survival. So this study came out, and I would just let you know to keep looking at JAMA because there'll be some interesting letters to the editor regarding this study that will be coming out shortly. So what is planned next? Right now, the standard of care for patients with macrovascular invasion and metastases is immunotherapy-based systemic therapy, atezo-bev, stride treatment, and now another ipi-nivo combo are approved in different parts of the world. So what does that mean for radiotherapy? I would hypothesize that the benefits of radiation, if anything, would be even more so as our systemic therapies improve. But I do believe there's a strong role for further randomized study. And this is one study that is being launched in the next quarter, led by Dr. Jennifer Wu from Boston through Energy. It's a randomized phase 3 study that is very similar to the RTOG study in patients Child-Pugh A, including B7. It's a pragmatic design that is comparing any approved IO-based systemic therapy, including those three measurements I mentioned, plus SBRT or protons in 5 fractions versus the IO therapy alone, with primary endpoint being overall survival. This is in development, but as I said, looking like it will open in the next quarter, and an important study that I hope will accrue much faster than the RTOG study. So with this trial and others that are in development, what does this mean for our guidelines? You heard at the beginning that EASL guidelines included radiotherapy. There are other many guidelines throughout the world, some country specific, some international, some hepatology lens, some oncology lens. There is increasing recommendations for radiation across most of these guidelines, which is terrific. It is the first step. The strength of recommendations are being improved, the indications are being expanded, but they are nowhere near where they should be for most of these guidelines, in my opinion. And we need to work together to advocate, share the effectiveness of our therapy, work with our multidisciplinary teams, invite them in how we work together to move the needle and improve outcomes for our patients. HCC is a complicated disease, really needs multidisciplinary care and teamwork. In anyone with any one hepatocellular carcinoma, they have a much increased risk of subsequent new cancers, and not all cancers can be treated with one treatment. And majority of patients do not have resectable lesions or tumors or a situation that is suitable for transplant. I believe the role of radiation will continue to increase. The NCCN guidelines in the US, I believe, need to have increased strength of recommendations and indications for radiotherapy. They're going to consider this in 2025. And there's actually a new guideline based from a HCC meeting called HCC Live that will be a North American consensus that is in development that will include radiotherapy with, I hope, relatively strong recommendations. So together around the world, I hope we continue to move the needle. As I mentioned at the talk, I really do think it's an exciting time for radiotherapy and for hepatocellular carcinoma. I would say strongly, without a doubt, radiation therapy is a very effective standard treatment for hepatocellular carcinoma. It is and should be in all guidelines. It is a curative treatment for isolated lesions. It is effective even in tumors that are very large, including up to 20 centimeters, with evidence that I didn't share for even very massive tumors. It is a pleasure to treat hepatocellular carcinoma patients in that it is relatively radiation sensitive, and we can have benefits from lower doses. I think it's a very exciting era with radiotherapy and immunotherapy, and hopefully the next era of trials will really show big benefits to radiation. I want to just end by thanking many people involved. Nothing is ever possible on own. Every trial, every advance in guidelines has been a team. Not only those who are mentioned here, but every colleague, observer, and experts in other fields of SBRT who've helped me along the way. It's an international, multidisciplinary effort, and many of my colleagues are my friends around the world, so it's been a pleasure. And finally, one last note for those of you who are developing programs or want to talk about liver and other upper GI radiotherapy in the future, we have a hands-on course in November. Every year we do, and it's our standing most popular course that we offer for multidisciplinary physics, therapy, dosimetry, and radiation oncology teams. We have 2 guest faculties shown here, and I welcome many of you to consider coming and joining us in Toronto if you're interested. And with that, I think I will end, and I have not been looking at the chat, but I will be happy to take any questions and comments and open up discussion regarding the role of radiation for HCC. Thanks.
Thanks, Laura, for a fantastic presentation and overview, a comprehensive overview about the growing and now guideline standard of being radiation oncology. There's quite some questions already, and I would like to get started with the palliative setting, despite you mentioned the curative setting, but there is patients which cannot be cured, and these patients need effective palliation. You showed this a very simple trial, single fraction of 8 gray. Is there any patient which you would not offer a palliative treatment in that setting, locally advanced massive hepatocellular carcinoma, no systemic therapy, in terms of size, performance
Yep.
status?
Yep. So that's an excellent comment. It's a small trial, so I think we need to keep that in our. And when you look at the patients who are actually treated in the study, there were very few patients with Child-Pugh C function, and so most patients had Child-Pugh B liver function, but many had massive disease. So in terms of the burden of disease, I actually don't. There's no limitations. The key is that you cannot give 8 gray in one without antiemetic and a steroid. So the one dose of the pre-medications is incredibly important. And the other, I think, exclusion criterion not in the study were patients with biliary obstruction. So with biliary obstruction, pain can happen, but also with edema, it could precipitate worse obstruction. So we do not treat those patients with this regimen, and they were excluded from the study. The other group of patients would be those who don't have pain. And, the study was those who had pain. So definitely in practice, it was actually very rigorous pain that didn't change over days. That was difficult. We do expand and treat patients pragmatically who are having a difficult time with their, for example, opioids without having, exact eligibility. And there's actually a spectrum of some patients having discomfort versus pain. And we do offer that routinely now. But patients who are completely pain-free, we haven't asked the question, does that improve survival? There's a variety of opinion as we wanted to launch a trial in that group. I myself don't routinely offer it. I occasionally do in patients who really have no options given their poor liver function and that hazard ratio we saw and the fact that some HCC is sensitive. But that is a group where there's equipoise. Otherwise, I think it's something that's pretty easy to do, and it's not technology dependent at all. The most important thing is the pre-meds, honestly. That's the most important thing to not forget. So hopefully that answered the question.
You mentioned a couple of times that HCC is a very radiosensitive disease. And we saw that in the spectrum of doses which is being delivered, single fraction of 8 gray, fantastic palliative treatment for pain. In your energy trial, the doses were as low as 27.5 gray in 5 fraction, going all the way up to
Right.
15.5, which we would call ablative. Do you have patients staying in the palliative setting where you would say, well, this is a young patient, he's kind of having a longer life expectancy, that you go beyond a single fraction of 8 to achieve potentially a more durable response?
Yeah, that's a great question. So the Canadian trial really looked at patients at end of life. End of life with palliative care despite interventions with even though there is improved survival with radiotherapy, very poor overall survival. And in real life, there are many more patients who require palliation who are not so end of life. And so the efficacy of 8 gray in one to improve pain is terrific. But if a patient does not have their entire liver with cancer, there's no reason you would have to treat the entire liver. It's an option, but you could treat with more focal treatment. And that opens up the window to safety, perhaps giving more repeat treatment. So I think that's one thing to keep in mind. The study showed 8 gray in one improves pain and doesn't hurt patients with whole liver. Extrapolating to that, I think partial liver radiation is also safe. So that's how we could use that earlier on in someone's natural history. The other thing is in patients who've done well, even from the trial, there were some patients who had good pain benefit who were alive at 6 months and the pain came back. So sometimes the question I have now is, can you give repeat whole liver radiation? I cannot say that 8 gray times one is safe giving it twice, but I have given occasional repeat palliative radiotherapy with 6 gray in one. Again, at the second time of giving it, usually that is near end of life. So I wouldn't advocate for that in patients' earlier natural history. But if you give partial liver radiotherapy, absolutely another 8 gray could help it. Or if someone we expect has a much longer natural history and the tumor is treatable with SBRT, for palliation, that is also another way to give radiation. So I'm not reporting pain relief with SBRT, but as you can imagine, with higher doses, you have similarly very effective palliation that's sustained. So SBRT can also improve pain. And if anyone, for example, meets criteria of RTOG 1112, we treat them with SBRT. That is our preferred treatment, even when in pain, because it's another effective treatment. It requires patients to stay still a little bit longer to time to start the delivery, but 100% that's an option. I hope there'll be future trials of repeat radiotherapy or earlier single dose radiation from whole liver of how we can do that earlier in patients' natural history, but we don't yet have one designed in that setting.
Laura, before we continue the questions, maybe you can stop sharing the screen. That
Yeah,
makes it more interactive to
perfect. Yeah, yeah.
exchange. Excellent. Um, there's another couple of questions. Maybe starting with a comparison of radiofrequency ablation of SBRT. You've shown, for example, the trial of XE in the JCO, um, and that was restricted to tumor sizes less than 5 centimeters. So, what is your take-home message on the comparison of radiofrequency ablation of SBRT? Is there still a threshold of 2, 3 centimeters where you would consider radiofrequency ablation as superior to SBRT in terms of local control? Only to say across the range of the 5 centimeter, it's actually the opposite.
Yeah, I am not aware of any data showing that RFA is superior in terms of local control in randomized setting at any size tumor. Um, some of the data, as I showed, does not have statistical significant difference. Um, but RFA and SBRT are excellent treatments for small lesions. And so for a 2 centimeter lesion that is suitable for both therapies, both are options. The difference is RFA is invasive. So there are disadvantages to that. Microwave is also invasive, but can treat a little bit longer. There's new treatments that some of you may have heard of, histotripsy, that is non-invasive, although it requires a general anesthetic and patients can have pain and or abscess. So even though it's non-invasive, it is more of an invasive therapy than external beam radiotherapy. So I think that's an important consideration in patients, as patients have poor liver function, low platelets, bleeding propensity. There are slight risks of RFA. For 2 centimeters or smaller tumors or 2.5 for smaller tumors, I'm happy with RFA if a tumor is very well suited for RFA and the patient's well suited for RFA. For larger tumors, we talk about it in our tumor board. Again, with microwave, there's also great control, maybe 3 centimeters, 3.5. But there's no question above 3 centimeters, the local control does go down with the IR typical treatments, and it doesn't, or very modestly for SBRT. So I would say SBRT is a better treatment for tumors larger than 3 centimeters. It is a better treatment when there is risks of RFA. So lesions near the heart, lesions near the porta, caudate lesions, difficult to visualize lesions, those would be where, regardless of the size, I would prefer SBRT to RFA, very much so. And I think that's where in our tumor boards we do need to advocate. So there's a role for both, but I think for the larger lesions, difficult locations, and or recurrences after RFA, very strong, would recommend radiotherapy versus RFA.
We have a couple of questions about the practice and details of radiation oncology. So one question is from Amina. Does the dose to the biliary structures kind of concern you? Would you dare to go beyond 40 gray, I guess, in 5 fractions to the biliary structures, or would you be concerned of strictures?
Great question. Biliary toxicity is something that doesn't tend to happen quickly, and it's not that reported on. I guess there's two kinds of biliary obstruction. So one is edema, and that's what I alluded to with the palliative study. A high dose perfraction could cause biliary edema that you need to be aware of, and that's you can monitor with your hepatology team or stent or give steroids, etc. But that's different. The toxicity that potentially can happen from high dose is a biliary stricture. It's not common. It's more common in heavily pretreated patients or patients with impaired biliary system, so cholangiosystems or primary biliary cirrhosis. So it's actually not very common at all. There's different guidelines from Stanford and others have put out. For me, I routinely exceed the dose that was in the question, 40 gray and 5. We contour the common bile duct or cystic duct in every patient we treat. We have that data. It's actually in supplemental data for the RTOG study in those patients where it was contoured. And we did not see biliary toxicity in that study. With colorectal mets, where there's motivation to give very, very high dose. I would not compromise the efficacy of the treatment for a bile duct, but we aim to not treat higher than the prescription dose. And I look at the dosimetry in detail when the dose is more than 50 gray and 5. And that's the philosophy we have. It's a late toxicity. It's good to be aware of it. It may happen 2, 3, 4 years down the road. And if it happens, to work with interventional radiology to modify it is important, but not to compromise treatment. So we're learning a lot about it. It's late toxicity important, but doesn't compromise the quality of our radiotherapy when the tumor is the most life-threatening problem.
There's another question of Maiden about the details of motion management. So what do you need for motion management? Do you need implanted markers? Do you need a CyberKnife for real-time tumor tracking? Is abdominal compression still something which can be done practice in 2025, or is that outdated?
Great questions. Kind of topics we talk about at the hands-on course. All of those are options. In our own system, people might not realize this, but even since 2003, we have never had fiducials. So we've had a complete non-invasive SBRT protocol over decades. What I was doing in 2003, I do not recommend now. That was planar imaging, MV imaging, and then planar KB imaging, and then fluoroscopy. But all of what was mentioned are reasonable options. There still is a role for abdominal compression or Ativan that can reduce the magnitude of motion and be included in ITV or a mid position. But better is breath hold, gating, ways to reduce the PTV margin, especially when there's risks. So HCC, big volumes, is more the fall-off dose in the liver that's concerned. But higher doses to small volumes, it's the conformality of dose that matters. And so reducing the PTV is important. With ITV approach with abdominal compression, there's extreme patients where you're unable to reduce the motion, and that large volume of normal tissue to be irradiated needs to be considered. It's not a contraindication, but I would hesitate before using the very high doses or 40 gray and 5 and higher. But 30 gray and 5, you can even do that relatively simple stereotactic approach safely. So basically, almost all technologies can be used. There is a role for fiducial-based gating and tracking. Some systems do that very well. The non-invasive approaches, I think, are perhaps more patient-friendly and can compete more with our IR colleagues. And there's definitely a huge potential that adaptive treatments can help. Quick adaptive treatments with the cone beam based platform, and also with MR guidance, where we have a better surrogate for the tumor itself. So many technologies, and depends what you have. You can work with it. You just have to do it safely. So yeah, I hope that answered the question. Lots of options.
I see in the chat that the enthusiasm about the energy trials is and HCC is kind of increasing. There's a question of Professor Ebersol, Daniel. Many thanks for joining. Is the energy trial going to be open for Energy International members?
I hope so, and that is the plan. At this point, the first goal is to get it activated and have Canada open. We're international. So we actually have some international rules too. And so we're in the midst of doing that. It's a pragmatic study. We don't have all the systemic options available, and we actually can't treat with IO-based therapy for Child-Pugh B7 patients. So we will only open it in A patients right now. But absolutely, that is a goal. And once it's activated and open, then the easiest way is with energy partners that are already opening. But I know we want to accrue it quickly, and I will advocate with Dr. Wu to do whatever we can to accrue quickly. So we'll keep in contact, and perhaps there are going to be other mechanisms of opening the study. I hope so. That would be great if
So
we could
please
work
don't
together.
forget about these new European states, 52, 53, so they might also be able to and keen to participate. Um, there's a question of Jakob Liermann about the positioning of SBLT with respect to TACE. You've shown the comparison of TACE and SBLT. Do you see room for SBLT combined with TACE? What is your opinion on that?
Um, I'm just sorry, I just lost you, but as long as you can still see me, I think we're good.
I can
So
see you well.
okay, good, good. So the question is SBRT with case. Well, I
Yeah,
mean there are trials. So I think SBRT and TACE, as I mentioned, there are some trials and experience mainly in Asia. So I think that absolutely is an option. There's provocative work from Hong Kong with TACE, radiotherapy, and IO. My own opinion or bias is that to use it's a bit of a layer up. Use the least invasive and less therapy you need for benefit in keeping the patient with good liver function so that there can be sequential therapies in the future. So we don't use TACE and radiotherapy routinely. I would prefer if a patient has TACE to see how the patient responds to TACE and then intervene earlier with a therapy like radiotherapy if it doesn't work and or if there's progression in a sequential manner rather than planned, or even perhaps better to go ahead with radiotherapy predominantly rather than TACE up front. Um, but saying that, given that there's level one evidence, I think that using TACE and radiotherapy, like the Yun study or like the Hong Kong study, is not unreasonable. But really a focus has to be on toxicity. So combining therapies, using them together, does increase the risk of toxicity. These patients can be fragile. And so anyone that has a decline in their liver function then subsequently may not be have options for systemic therapy. So I think that's the big principle in whenever we're combining therapies. And as I said, my own preference would be to use single modality, not TACE and radiotherapy, but move more to radiation and systemic therapies, in my opinion.
I would say this is the best conclusion you can have about such kind of sessions, how to kind of make preference for the benefit of our patients. Dora, many, many thanks for this virtual around in radiation oncology lecture. It was fantastic. And many thanks to everyone for joining, for asking super exciting questions. And as you said, we are so proud that you have been contributing here to move the needle. We are trying to pick that up, bring it to our tumor boards and support them to give the benefit to our patients. Thanks a lot for joining and wishing everyone a good afternoon, evening, or wherever you are. Thanks a lot.
My pleasure. Thank you. Take care.